All right, welcome to the Pierce County Council Public Safety Committee meeting. The date is June 23rd, 2025, and the time is 1:30. Clerk, can you please call a roll?
Yes. Councilmember Yombe.
Here.
Councilmember Hitchin. Here. Councilmember Burrell.
Excused.
Councilmember Denson.
And she's excused.
And Councilmember Herrera.
Here.
You have 3 members present.
We have 3 members, so that's a quorum. Item number 3, approval of the agenda. Is there any changes to the agenda? Hearing none, the agenda is approved. Item number 4, approval of the minutes for June 9th, 2025. Any edits or corrections to the minutes for June 9th? Hearing none, the minutes are approved for that day. So we're going to get into item number 5, which is really important. For the record, Committee Member Denson is here. But this is a very important subject today, and we felt that this committee thought this was really important to talk about it on a public setting. So I really appreciate getting things together. We're going to have Miss Kelly give us some introductions.
Thank you, Chair Herrera and committee members. For the record, Andrea Kelly, council staff. Today, and you should have a copy in front of you of the Pierce County Health Department's quarterly drug-involved death report. This comes to you from proviso language, which directs the Tacoma-Pierce County Health Department to submit a quarterly report to the council compiling fatal overdose data, death data in Pierce County to include geographic and demographic information as determined through consultation with that data coming from the medical examiner's office. So the Tacoma-Pierce County Health Department analyzes the data after receiving it from the ME's office, and we had presenting as a panel today, so I would ask the panel members to come up. We have PhD Ingrid Freiberg, epidemiologist with Pierce County Health Department, PhD Cam Solomon, epidemiologist with Pierce County Health Department, and Luke Vogelsberg, Director of Operations with the Pierce County Medical Examiner's Office. Additionally, online, we do have PhD Shanice Owens from the Tacoma-Pierce County Health Department, who is the Director of Assessment, Evaluation, and Epidemiology.
Okay, thank you. Welcome. If you could turn your name tags around, that'd be great. So
we don't need to see our name.
All right, that's great. Appreciate that you're here today. It's real important to this committee and the council and Pierce County of what's kind of going on out there in the streets, and what you're seeing out there, you know, when it comes to trends and things like that. It touches me to the heart because, you know, my previous life, I've had to deal with folks out there. Narcan, dozens and dozens of people, seeing the real human impacts of that. And I hope today, not just talking about numbers, that we kind of find avenues and solutions and pathways to prevent, help, whatever we can do, and to get ahead of these things by looking at data to predict some trends, habits, and idiosyncrasies as we move forward. So thank you. Welcome. And those should all be on, right?
Are these, okay, so they're on? Okay,
Yep.
Great. Well, thank you very much, council members, for inviting us to come here as representatives of the medical examiner and Tacoma-Pierce County Health Department. We're really pleased to have this opportunity to just share the information that we've been gathering and to really highlight some of the idiosyncrasies of how the system works and how we can work to improve the information that we have available. So, next slide. We're going to start by summarizing a little bit about the death data that we work with, because that's what we are most aware of. And then we're going to highlight 3 different pieces of information that we have, which are based on the medical examiner's data. The first is the annual report that the Tacoma-Pierce County Health Department has been doing. We've done one version, we'll do another, I'll mention that. We'll talk a little bit about the quarterly death report and a little bit about what goes into it and why it's the best we have, but it's not perfect. There's no perfect data in this world, and I will say that 1,000,000 times up and down, there's no perfect data. And then, of course, we have a new death dashboard based on the homeless population in Pierce County that Luke will be presenting with the information there. And then we'll talk a little bit more in detail about the data around homeless individuals. So hopefully that's what you are looking forward to hearing. In our next slide, will just give us a reminder, as you mentioned, Councilmember Herrera, every life and every death has a story. These are individuals, and they are important people. They are not just numbers. And some people don't always like it when we start thinking about the numbers because it seems so cold. But we think about it as a way to really make improvements, to make changes, to understand what's going on. And so we're hopeful that by analyzing all of these particular individuals that we can really make some improvements and prevent future deaths or delay future deaths. Next. I'm going to start by talking a little bit about the flow of data because this is the part that's really complicated and really confusing and actually is what causes a lot of confusion in many different settings. And I will say I'm only looking at the medical certification. So when a person actually dies, different people have the opportunity to share that information with the state. So these are the medical certifiers. And so one of the most common medical certifiers is the medical examiner's office, and they'll talk about what they do. The other place that this information can come from is all of the other medical certifiers in Pierce County. The third one is the out-of-state deaths and the out-of-county deaths, and I'll mention those in a moment. But when we take those medical examiner certifiers and the other medical certifications, we pull that together into a particular data set, next, which is fed into the Pierce County Vital Records. It's a new data system over maybe the last 3 years, and it's called WALES. It doesn't matter what it means, but that's what it's called. And this is where we gather all of the deaths that have occurred in Pierce County, whether or not it was the medical examiner or somebody else who's looked at it. And then together, that WALES data set with all of those others that come through from out of county and out of state, those get combined into the DOH records. Next. And so then DOH takes all of that information and they spend a lot of time cleaning it up, organizing it, making sure that it's perfect, approving everything and sending it off to the Centers for Disease Control. And that's when we have a final death record about 9 months later, and then they're willing to send it back to us. Next. And so we get a data set, which is the deaths of Pierce County residents. So that takes about 9 months after the end of the year for us to get that. We can't get that any earlier because of all the work that this Department of Health has to do to clean that up. So when we talk about data sets that we can look at to understand, that's an important one, but it's delayed. Next, click. The other one we can look at is actually the data from the medical examiner, and we're going to compare and contrast those in just a moment. And then we have a new data set that we're getting access to right now, click, which is the provisional deaths, which are only the deaths in Pierce County. They're coming to us on a monthly basis, and we're going to be using that for some of our work with the homeless data. But that's a new data set. And so, as you can see, this flow is very complicated, pulling information not just here where we're showing the medical certifiers, but there's also information coming in from families and funeral homes as well at the same time. So there's a lot of work to make sure that we're giving the right information to all of us who works with that. Next. I mentioned briefly that we do an annual report for the deaths of Pierce County. And what you'll see here is on the left is the 2021 information, and the right is 2022. And what we see here is of all the deaths that occur in Pierce County, what we see is that only about 17%, which is that dark green section in the top right, only 17% of them are actually going through the medical examiner. So we are not looking at the majority of deaths by any stretch of the imagination. We're just looking at a subset of those. There's an additional 20% that get reported to the medical examiner, but the medical examiner declines jurisdiction. I hope I get the words right.
Yes, that's exactly right. I'll get into more about when a death might be reported that we decline shortly.
Yep.
Right. And so it's just, we don't see all of them. And then what you can do is you can look at the next slide. And this is just a summary of the comparisons. And so I'll let Luke speak for the medical examiner's data.
Sure. So the RCWs establish which deaths are reportable to the medical examiner, and basically, to briefly sum it up, it's deaths that are non-natural or might be non-natural. Suspicious things or injuries, intoxications, things like that. The vast majority of people in a community die natural deaths. Most deaths are not reportable to the medical examiner's office and thus aren't reported. So it's really important to highlight that our data is not reflective of the community at large. Non-natural deaths are going to be significantly overrepresented in our data, though we do certify some natural deaths in various circumstances. For instance, if there's a concern that something non-natural contributed to the death, we do an autopsy and learn that there was no injury, we might certify the death as natural. So those are the small handful of deaths that we certify that are natural, but the vast majority of what we certify are non-natural deaths, which means accident, suicide, homicide, or undetermined. And I like to point out that undetermined doesn't mean we just threw up our hands and gave up because it was too hard to figure out. It means that there were two or more equally compelling options for manner of death. Often these cases are skeletal remains found, in the woods or in one of our national parks with no obvious anything to explain why they died. Our work, as Ingrid mentioned, is relatively timely. We certify deaths within 48 hours of being notified of the death or doing the autopsy. Sometimes those the cause and manner of death are certified as pending until we get further information back, which can take 12 to 14 weeks usually. Specifically toxicology reports. This isn't just a line that we like to say. It really does take that long due to different phases of testing and different steps that need to happen in order for the testing to take place. So a number of them are pending for a time and then get updated later with the final cause and manner of death. I think that's about it on our...
So I'm going to allow the committee to ask questions as we go along, just so we keep on point. But I do have a question. So are all drug overdoses... They're not. It's not a natural death. So are they all of them reported to you?
I hope so. We're heavily dependent on reporting agencies. I think specifically with hospitals.
Yeah.
If someone has a drug overdose event, goes to the hospital, and then stays alive for some time, by the time that they ultimately pass away, if they do, say, 3 weeks later, the clinicians are treating them for their ventilator-associated pneumonia and have no idea what brought them into the hospital in the first place. I fear that we are missing some cases that way, so they don't get reported because they, by all accounts, it looks like they're in renal failure or have pneumonia, and it might not get reported because there's no obvious injury having caused this. Across the nation, there are, in the majority of other jurisdictions around the nation, there are processes in place to catch those as well, where the medical examiner does some level of review on all or almost all deaths in the county. Even if the person dies at the hospital and aren't reported, the medical examiner would review the death certificate at minimum before the body can be cremated or buried. That process does not exist here. I think it's a small number, but it's I don't know what I don't know. So
I'm going to throw a what-if scenario,
Sure.
because a lot of times someone will be found, they'll get Narcan, maybe there's a little heart rate, or they're on CPR. It's in Tacoma, so they can get them to the hospital, but they call it at the hospital.
yeah, that'll be reported.
That's still reported to you because it's in their jurisdiction.
Almost always. Yeah.
Okay.
Effectively, every emergency department death is reported to us.
Okay. All right. Thank you for that clarification. Okay.
And the only thing I want to add to that is that we were talking about data, and the data that gets gathered by the medical examiner is for the purposes of understanding that cause of death. So there might be pieces that aren't gathered because it's not relevant for understanding the death. And they have all of the names and all of that information for an individual. And I specify that simply because when we get the Department of Health death records at the 9 months after the end of the year, it's a little bit different because, one, it includes all deaths of residents of Pierce County. It includes any out-of-county death. So if somebody were to die in King County or Indiana, those deaths would also get reported in this particular data set. So we are very comprehensive.
So meaning that they are a resident and they were visiting in Indiana and passed away over there, or they're in Seattle. Okay. All right.
Yep. Or if you just had a drug overdose in Seattle while you lived here, that would not go to our medical examiner. That would go to theirs, but we would get the record when we get the final data set 9 months later.
Okay.
So there's obviously confusion. Of course, there's, like I said, September a year later, so it's very delayed in terms of being comprehensive. But there is a lot of quality control, so we're getting all of those other pieces of information, and it gathers all of the information from the medical certifier as well as the funeral homes and the families. So it's a very good data set. The other thing is that our current data sharing agreement, which is what we have with the state to allow us to look at that data, is anonymous. So we do not have the names of those individuals at this time. We know that there's a possibility that we can change that in order to get those names, but at the moment that is not the standard, and it would take some time to change that so we would have the names of the individuals in that final death set. So just makes it a little bit different. Next.
I have a question.
Oh, well, we'll have a question. You can speak later, right now during the thing. Yeah. Appreciate it.
And this was just a list of everything we have, which is all the deaths that are reportable to the medical examiner, so the types of deaths.
So all non-natural deaths. This is established in RCW 6850.010 with all of the different things that are reportable to us.
Next.
Yep.
This is just, there are, as we mentioned earlier, there are a bunch of different data sets, and so this is just where, no, data sets, bunch of different results that we want to talk about. And so on our next slide, this is on their dashboard. The medical examiner has a dashboard, and they summarize many different pieces of information. This is what you see when you go to their data dashboard. I'm actually going to start with the annual report. Click. And so we'll start with that one because it's just relatively straightforward. This is a report that we've been doing. We finished the first one last year. It is a collaboration in every which way, shape, and form. It is all of their data, and we talk through all of the nuances and the understanding of what's going into it. So I think it's as comprehensive as we can get. The second version of that, which covers the data for 2023, is in the communications portal process. So it's been finished, but it's not finished yet. And this particular one, remember, we've only talked about the deaths that are reported in Pierce County to PCME. When we were developing this, we had to look at new ways to do things. So one of the things that we did was search the data to look for homeless deaths, because we knew that that was also an important thing to look at, which means, once again, we're looking through the words that people are using to talk about this, which means it's not perfect. But we'll show you some of the changes that we've made since then, or they've made since then. We also were very interested in the location of death and the location where the incident happened, what type of place it was, and we discovered that there was no standard way of figuring that out. So we developed some new ways of looking through the words to try to figure that out as well, because we just didn't know what was going on, and we wanted to be able to do a better job of understanding where people were, when they were dying, or when they were having an accident or an injury that led to death. Next. The next piece we'll talk about, next, is the quarterly drug-involved death reporting. So that's that middle box there. And this is the report that you have been getting every quarter from us. Once again, it is a collaboration. Next slide, please. As you can see from the report, and I brought my own copy as well, we do our best with what we have. We do get all of the information that we can. We have seen a decline in deaths due to substance use, but they may have been increasing a little bit recently, which is unfortunate. The next iteration of this report is coming out at the end of July, so we'll have that information. And the reason we do this every quarter is because, well, as Luke said, it takes some time to gather the information.
We have a question from Committee Member Hitchin.
Thank you, Chair. Thank you, Ingrid. One of the reasons we funded an additional person within the medical examiner was really trying to be intentional about tracking overdose deaths, but also what types of drugs are involved in overdose. So for even this information, it's 9 months before we know, because one of the things we were it's hard to hope for things like this, but hoping for us to be able to respond if there's something in the community that's causing more harm or is intentionally, laced items that people think they're taking one thing and they're not, or it's I'm going to use a bad batch. That's a term I've heard. So if we're waiting 9 months, that's not helping us. I'm curious.
So the data that's going into this report is not the 9 months.
Okay.
This is only about 3 months is what it is. So it is more delayed, and we're just waiting on the laboratory reports.
Yeah, the tox reports take time for us to confirm the substances involved. I will say that at the beginning of this year, we did start participating in a program called OD Maps, where we are entering cases in real time with suspected overdose information and suspected substances. I don't know, who else in the community is using that, if anyone, but we are putting and it creates a beautiful map for you of, hotspots and You can look at all these different trends in this platform. It's administered by the DEA and HIDA. So I think there's some reluctance to use it for various reasons, in that, there might be some fear that law enforcement is going to use that as a way to target enforcement operations versus using this to help prevent further overdoses. I don't know. We're putting in what we can.
Okay. But a hospital, so if someone were to overdose but then die in a hospital, would the hospital be the one that would put it into OD maps, or
They could.
you? Okay.
The people that can enter stuff are hospitals, EMS, law enforcement, and medical examiners and coroners. So I don't know what other agencies may or may not be using this, but we are putting all of our suspected overdoses in usually the following day from the day that it was reported to us.
Okay. Thank you. Thank you, Chair.
Yes. Quick follow-up question. You talked about the getting toxicology reports back. Is it due to the process takes some time, or is it the volume?
I think it's probably a mix of both, but truly the process does take some time with different phases of the testing. I'm not going to pretend to be an expert toxicologist.
Sure.
And I'm able to really just report how it's been reported to me, but there's phases of the testing. One step needs to be completed before you can move on to the next one. There also is a volume issue. A lot of our testing we typically send directly to the Washington State Patrol Toxicology Lab, where they then send it out to a private lab because they don't have the ability to manage all of the death investigation toxicology testing. But it does truly take typically anywhere from 9 to 14 weeks to get things back. And then once we get the result back, the assigned case pathologist has to interpret those results in the context of everything else. They might be looking at histology slides, other laboratory tests like microbiology cultures, other things. So it's not like as soon as we get the tox back, now we can be done. Now it all has to be interpreted in the context of all the other findings.
Thank you.
It's that CSI effect that people think every medical examiner has a machine. You just drop something in and it spits it out. And
Yeah.
okay.
Thank you. Continue.
And so, as I mentioned, we think that things are going back up again a little bit, which is unfortunate. But we have noted that fentanyl and stimulants are the most common substances that are identified and reported in there. We use 3 different fields from their records, their final records, to just calculate it, including cause of death, how the death occurred, and what are the significant factors leading to death. It's important to realize that most of these deaths aren't just one substance. We found 67% of the deaths are really more than one substance. And even there, the toxicology is limited to what they're testing for and what they're finding. So we can't even comment on things that we have not found or because we have not tested for them. But
On the testing, is it just your request of what to test for, or is it like a 16-panel test? Or
There's 2 different options that we run typically, a basic panel and a comprehensive tox panel. The comprehensive panel has probably a couple hundred different substances included in it, and the basic panel is, I believe, basically any drug of abuse that you've ever heard of would be on it. I don't know the total number of what's on it, but we often do urine drug screens during the autopsy exam that will help direct where we're going to send the testing. If the urine drug screen is positive for fentanyl, we're going to get a comprehensive panel because that is the only one that includes the fentanyl analogs like acetylfentanyl and acrylfentanyl and carfentanil. So if they test positive for fentanyl, we want the analogs covered. If they don't, if they just test positive on urine for methamphetamine, we might just do a basic panel.
And real quick on the, you said that the drug involved has peaked in 2023 and they're going up here in 24. Based off of like in all mankind's history or the last 5 years, or what is that based off of?
the peaking of this?
Sure.
So I've gone back, so when it comes to looking at these, I would say I've gone back a few years, but it's not like they were that high a few years back. So, and also fentanyl wasn't really noticed, so it was this very low level, and then it's peaked, and it's coming down from that peak, but it's not anywhere near those low levels that we've seen before. But I cannot compare it to other drugs as they were being introduced into society. So I haven't done that particular research yet.
Okay, thank you.
But that's the right question to ask. I really like that question. And I do also want to point out that even though we talk about fentanyl and stimulants and other illicit substances, we know that prescription drugs are also commonly found in people who overdose. So that is not something to ignore. It's relatively common. We know it's more male. We know that it's about 40% of all of the drug-related deaths are in the age 55 to 74, so we're not talking young kids. It is much more in that older population. Now, we did note that fentanyl deaths are slightly younger, but that's still that 35 to 44 age. We're still not talking teens or early 20s. We're talking a different age group there. Next. And I just want to point out, we've just talked about this, the long lag, so there's nothing more to say about that. We cannot evaluate every substance. The other thing to say is that it's not including every Pierce County resident who died. When I looked back at the data for the past about 10 years, 2016 through 2023, we saw that 9% of all substance-related deaths of Pierce County residents actually didn't happen in Pierce County. They happened in other places. So it's not something we can say it's just a county, because people are going other places as well and dying of substance-related disease. And the other thing is that the people who are dying in Pierce County are not just Pierce County residents. I looked at the first quarter of 2025, and there was one out of the, I don't remember what the number was, who died who wasn't a Pierce County resident. So there's a lot of overlap and back and forth in understanding what's going on. And
Right.
that's it for this one. Next. And the last piece that we're going to be talking about is the data around deaths presumed to be experiencing homelessness at the time of death. There we go. And actually, is it possible for you to click on that link? It should be a live link, because that would take us to the actual website. Sorry for not asking earlier. There we go.
All right, perfect. So part of the request for this presentation was to walk you all through some of the data that we're sharing on our website now. And it has
Disappeared.
Wait, you want to talk about that on those lines?
Yeah.
Yes, please. Thank you. So I think it's really important to start with this. We already saw a figure on the slideshow earlier kind of highlighting this, but I really think it's important because I don't think that the general community really has fortunately for them, doesn't really have an understanding of what we do and just think that we're the end stop for all things death, and we're really not. We added this graphic here to show the substantially fewer deaths that we actually get involved with as compared with all of the deaths in the county. We don't touch anywhere near all of the deaths in the county. So the dark blue bar is the total deaths in the county year over year from 2020 to 2024. The green bar are the deaths that we actually exerted our jurisdiction over, meaning we think that there's enough here that this could be a non-natural death that we need to investigate, or the handful of cases of apparent natural death, but the person has no known medical history, has no doctor, there's no one else to sign their death certificate but us, so we take that on. If we could scroll down, please, and click on the data of individuals presumed to be experiencing homelessness at the time of their death. So we heavily disclaimer this data for a number of reasons. One, as I just said, we don't know about all the deaths in the county. There very likely are people that were unhoused at the time of their death that died a natural death in the hospital. It was never reported to us. We don't know anything about it. Secondly, determining someone's housing status is not easy. We are left, we're called once there's a death. It's very variable where we can get good information from. There's obviously clues, like if they were found deceased at a tent encampment, that might be a clue that they were unhoused. It's based on witness statements that someone might describe this person as homeless, but it's pretty subjective. And additionally, on the actual death certificate for the state, there's two different places where the decedent's housing status is captured. One is by the medical certifier. In these cases, that's us, where it asks if this person was unhoused at the time of their death or within, I think, the last month preceding death. Additionally, the informant, which is the person making funeral arrangements, also gets to answer basically that exact same question, and we might provide different answers based on the best of our knowledge. So this data is not perfect, as Ingrid kept telling us. It's very difficult. So if we could move to I want to point out one thing here too. You see the giant spike here for quarter one of 2025. I don't think that that's probably real. I think that stems from an improvement we made to our case management system to better track these. Previously, there was a multitude of different ways these deaths were categorized in our case management system. I put it into that beginning of this year, just made a checkbox, presumed to be homeless. So it was very simple, one place to click, and now we can find them all with relative ease. So I suspect that that jump is likely most related to the improvement in our data collection. If we could move to manner of death, please. So this is just a representation of the, I guess, 6 different options for manner of death of our unhoused community. The big blue bar at Q1 of 2025 are pending, so these are cases that we're waiting for toxicology probably and other testing to come back on. You can see that the vast majority of them are non-natural, but again, that's impacted by the fact that we only really get involved in cases that are suspected to be non-natural.
We've got a question from Committee Member Hitchin. I think you're on.
Yep, thank you, Chair. Luke, with our data around homeless, you said that there was this spike. I guess what I'm hearing from you is it's potentially like we now have better data. These are more reflective of the numbers, and for a while we've been missing. It's not that suddenly.
Yeah, I suspect that this is mostly representative of the fact that we've improved how we categorize these things, so we're able to pull these cases when we query our database with more ease.
Okay.
I don't think there was a significant spike in actual homeless deaths.
Okay, thank you. And then I guess my second question is, we use HIMIS in, I never remember what it stands for.
Homeless Management Information System.
Thank you.
Familiar?
But is that part of the data set that you and your team use or the hospitals use to help be able to check that box? Like,
I can't speak for the hospitals. I know that we don't have access to it. I've talked with the Human Services team about getting access to it. I don't think there's much use for us to have full access. They've been working with us. If we need information out of it, they are happy to help us and talk to us about specific cases. But with all of the data that it holds, I don't think that it would be responsible data governance for us to just have full-blown access to their system.
even just knowing names and ages of people, though, so that you'd be able to, like, if someone comes in and we have a name, they were in the hospital, but.
If we need that information, we can easily get it from them.
Okay.
Typically, we have a pretty good idea of who the person is by the time we get involved, and then we make efforts to scientifically confirm their identity. But when we have run into this, that's where it's been useful. We've got everyone just knew this guy as Jerry, and we were able to use HMIS and then to find people that they knew and track down leads kind of backward to figure out their actual identity. So we do have access through their staff.
Yeah,
Okay.
and we're going to be talking a little bit more about that HMIS at the end.
Okay.
But we are going to be trying to explore different ways to do that. I'll be talking a little bit about that.
I will hold the rest of my questions then.
Okay, all right.
We can move on to accidental death classification. So this is where we have kind of split the accidental deaths of our unhoused community into 4 different categories: substance use, trauma, environment, and other. Other might just mean that there were multiple of the other 3 options. So it might be the death may have been certified as being due to intoxication and cold exposure. So it gets classified as an other category. You can see that substance abuse quarter over quarter is the leading cause of accidental death in our unhoused community. I don't know if anyone has any questions on that before we move on to if we want to see the by sex assigned at birth. We can see a comparison. There are more males than females dying while unhoused. We've got a breakdown further down in age group. And then by location of death, we just split that. If we could click on that one might be interesting to look at, the very bottom. We basically split it into the 3 largest municipalities in Pierce County and then not there. So there's Tacoma, Puyallup, Lakewood, and other. And you can see, obviously, that Tacoma is the leading location, but I also caution you with that. There's a disclaimer at the bottom that often people will die a non-natural death or whatever at a hospital in Tacoma. They may have suffered some fatal incident somewhere else and were brought to a hospital before being pronounced dead, and this is based on their location of death. So Tacoma is likely slightly overrepresented. I think that is it, unless there are questions around that dashboard.
Any other questions?
And so, next slide. So now we were going to go into that whole question to talk about the homeless data, because it seems like a relatively straightforward question, but as Luke said, it is not straightforward. Next. So this is sort of asking us, like, how do we know if a person is homeless or not? It used to be, and I'll go back several years, that we had an electronic death registration system, and you could pull anything out of there from our vital records team, and they would be able to say, these are all the people who do not have addresses. And I know that was shared with community members. It was readily accessible. It was very easy. And then from our annual report, we basically did searches to find people who had words that sounded like they were homeless or other pieces of information were missing. So we had ways to do it, but it's a little bit harder. So currently what we now have is our Vital Records has this new data system called Wales, and they send Cam here a list of all the deaths that are occurring every month. And if you don't have an address in there, then that is a potentially homeless person. But this isn't a perfect match, because somebody could have an address because their parents found them or had said that they lived with us, but they're actually homeless people because they choose to not live with their family. So it's a very messy situation right there. But as Luke mentioned, in January, they added a checkbox to every report, so we now have better information on that. It'll take a little while for that to feed into our systems, and I'm going to actually add information from that checkbox into the quarterly report when I do that, but I won't be going back before January 1st, because we know that the data before is not going to be truly comparable. And then, as Luke mentioned, the Department of Health has started adding fields around medical, about certification, but we don't have access to that yet. So DOH is working on that, and we're literally waiting for the data sharing agreements to be finalized, because it takes time for them to work through the development of this question. And so when they're ready, they will give it to us for 2023 onwards for that dual question and all the information around it. So soon we will have better information, and now I'm going to hand it over to Cam, who knows all the other homeless information.
Yeah, I mean, that's I think a little bit optimistic. They've put the state DOH, as you guys know, are going through some budgetary issues and layoffs, and they've put a hold on DSAs right now, and so hopefully they will restart that, and we'll get the dream is that they'll give us a comprehensive report of all the people that they have identified as experiencing homelessness at death, and it'll be sort of a parallel report to our total death files that they give us, but we're not, we're trying to look at contingencies to try to improve this data. In case that doesn't, takes an extra year or so, we don't want to. I know, this is a pressing issue, and it's something that we really want to improve the reporting on. And I know that it ended up in the press earlier this year, and we started brainstorming how to maybe identify. The people who are experiencing homelessness among the deaths in a more comprehensive way, because as Luke said, he only looks at a small minority of total deaths, and so I'm the HMIS administrator for the health department. The current DSA is very limited, and I can't really use it for very much, and so I'm trying right now to work with Pierce County Human Services to expand that DSA so that we can get a comprehensive list of people experiencing homelessness at a given period of time, do a linkage, next slide, thank you, a linkage with HMIS and these monthly vital records reports that we get in a much more timely fashion than the they're preliminary, but they do I think they will provide some information in a much more timely manner. We just have to make sure that people understand that data is going to be changing over time. But I think that the timeliness is probably worth it, given that even if the accuracy isn't quite what we would want. So I'm working through with Pierce County Human Services to get this HMIS data set on a monthly pull so that we can link it to the vital records. We're going to have name and date of birth in both of them, and that's not always perfect, and so we're going to have to do a little bit of fancy coding to try to do some fuzzy matching and things like that to try to identify those who died who were at that time experiencing homelessness. And that's, and then at the same time, we would love to be able to sort of verify with the medical examiner's data so that we can have all three and we can kind of connect the dots and get a much better idea of and a more timely idea of people of those who are experiencing homelessness that have died in the county. So next slide.
So I have a quick comment
sure.
on a little bit of that. I think it's really important, especially working with Human Services. Some have talked about how, we're kind of in a phase of housing unhoused folks, and we want to have good data of tracking folks if we are able to. You've already told us how hard it is, but this might be even harder to track unhoused people as we house them, because we don't want to house them and then just walk away, and then they're, instead of dying in a tent in the gully in Tacoma, they're dying in the housing we provided.
Yes,
as we move forward, that's why it's important to track, at least in my opinion, what we're doing.
Yeah, for sure. And the HMIS, the Homeless Management Information System, has not just people who are living in a tent in the woods, but also people who are who we have sheltered both temporarily and permanently. Anybody who touches the homeless system and gets services from Pierce County Human Services is in this system, and oftentimes they are not actually considered unhoused by there's multiple definitions of what it means to be unhoused, but the HUD definition is like the standard. That's got money involved. But so we can look at the multiple definitions and just determine how expansively we want to look at those that are in our homeless system or tightly, depending on probably the context in the question.
Thank you. All right.
So I'm thinking that if we haven't really seen this data, and data is always messier than you expect. So we're hoping that this will potentially be a more complete assessment of those who died while experiencing homelessness. Hopefully more accurate, especially if we triangulate all three of those data pieces, and to some extent more timely, even if we do get that big, DOH pure, completely, clean data set from, 9 months later. 9 months is a long time, and it really, a lot of things can change very quickly in the unhoused community. So it would be great to be able to at least get a preliminary look at that on a monthly or a quarterly basis. So, yeah.
All right. Okay. Any other? Okay, we got some questions coming up. We'll start with Committee Member Hitchen.
Thank you, Chair. Thank you, Chair. I think for me, around the sharing of the data, I kind of want to understand the timeline. So the 9 months is the formal, goes through the whole process. But if we're looking for trends or ways to respond, or where we need to shift investments or even respond to an emergency, 9 months doesn't allow us to do that. So with this data sharing agreement, is there going to be an ability to provide to our human services and on the streets and to our providers, if you're seeing something from the health department, and more like a monthly? I'd hope sooner, but I know it takes a lot of time.
Yeah.
So
I was trying to get full system access of HMIS, which would give us, we could be tracking things on a day-to-day basis. We don't have the manpower to do that, obviously. Right. But we were negotiating a monthly polls for them to supply us a monthly data set from HMIS, so that we can do that linkage on a monthly basis. And hopefully it'll be complete enough that we can do this kind of work. We don't know until we see the data, but
I was going to say, and that's the limit, the time frame, because let's say we get all those data agreements in place where we can have the medical examiner, the HMIS, and the vital records. It will still take us a few months to figure out how to make everything work together appropriately, do the quality checks to make sure that we're getting the right information, because we do want to share that information, but we also don't want to share incorrect information. So it'll take a little while, even once we get those data sets in place.
Okay, so I know we have some experts, including someone in the room who sometimes spends time in that space. So just reach out if there's ways that we can support. I know there's a lot of interest, especially around cold weather investments, chronic disease investments, and then also heat. Just understanding, because we are starting to try and be more systematic about how this county responds. We just heard this presentation, I think 2 weeks ago, on how we respond when inclement weather is there, and are we investing in the right places? We don't actually have data to support that investing in hot weather response versus cold weather response is actually saving lives. And then what about rain versus snow versus wind? And this kind of data moving forward, I think, will help kind of paint that picture, especially when we have limited resources when it comes to funding, but also just people power, like which is the most catastrophic. A question that was not asked is around people who die in the hospital. If they're unhoused, but they're in the hospital, they've been there for a while, they didn't have a way to discharge, but then they pass, they don't go to the medical examiner for an autopsy.
It depends on what brought them to the hospital in the first place in the ideal world, right? If they entered the hospital and ultimately died as a complication of some non-natural thing, like an injury or an intoxication, then yes, they should be reported to us. If they entered the hospital because of a natural illness and ultimately died of that natural illness, it would not be reported to us.
Okay. So even though possibly being unhoused is what caused a chronic disease to become, let's use kidney failure, can't get to dialysis, can't get to medication, can't get to clean, stable food, so they die prematurely, how would that be reported? That wouldn't go to you, is what I'm hearing, because it's a chronic disease.
Social determinants and things like that aren't considered in the cause and manner of death statements.
Okay.
So no, that would not be a reportable death.
And that's one of the ones where we'd love to really look at the DOH data, because as Luke mentioned, they're going to be having two questions. One is, were you homeless at the time of death? Were you homeless a month earlier? So we should be getting a little bit more information about those people who've stayed in the hospital for a long time beforehand.
And
we won't get everybody, but
to capture more. And we will have that data not 9 months, like that one we don't have to wait 9 months for?
No, that's still the waiting 9 months part.
I am actually negotiating right now. Going back to that DSA question, I am negotiating with Pierce County Human Services to maybe expand it to our hospital databases so that we can see hospitalizations due to heat or to cold. I mean, cold is generally, in usual years, it's like 4 to 1. The cold is the killer. But then, in June 2021, that wasn't true, because that we had a huge spike in, and a sustained heat dome that didn't allow people to cool off at night, and it was also earlier in the season, so people hadn't become acclimated. It was so it's not always the case, but usually cold is what we would focus on, but we shouldn't ignore heat either.
Okay. Thank you, Chair.
Thank you. Committee Member Denson.
Thank you, Chair. And I'm not sure if you can talk to this or not, but you've mentioned a couple times negotiations with Human Services to get more HMIS data on a more timely manner. Why can't you just have the same access? Like, why can't you have full access if that's going to help the data set?
It's there's a lot of very sensitive information in the HMIS data set, and they're very protective of that. I mean, there's people who are experiencing domestic violence, and there's people who are in very precarious situations, and that you don't want that information to be getting out in any with people less careless than the Pierce County Health Department, Tacoma-Pierce County Health Department, and so their lawyers have been are pretty careful about access and who they grant access to, and that's I kind of understand it. I mean, yeah. But at the same time, and honestly, given our manpower situation, it may be that giving us a clean monthly data set is all we can handle anyway, in terms of the work that we want to do with this data. But right now it's just mainly negotiating use cases, data sets that we can link, we're allowed to link to, and at the same time, like the hospital data, we would actually have to go to the state and get another a modification of that DSA so that we could do that linkage on that side, because we don't currently have that permission.
So that's a completely different DSA
Yeah,
with the state to get the hospital data, and you're working on that as well?
Yeah. So we'll try to do that as well. We're doing, so there's a lot of different use cases. We can use it for immunizations, so we would want a DSA to link to our immunization system. There, you can do outbreak investigations, so we would want to link it to disease investigation data sets, and then the hospitalization data set as well. So there's a huge amount of opportunities to really improve our information around people experiencing homelessness and their health in Pierce County, and it's just a matter of there's a lot of paperwork.
If there's anything we can do to help.
But I don't think it's just Pierce County that's having this. I mean, it's very difficult because you do need to negotiate all of these agreements, and I think we're lucky to have a medical examiner. They've got a checkbox, so we can work with all of these different pieces, and we're trying to improve it. But we also do need to worry about the people who are experiencing homeless as well, in the sense of we don't want their information to unintentionally go in the wrong places.
Okay. And then my other question is maybe the same as Committee Member Hitchen. I'm struggling a little bit with the timing because, for example, as new substances come into our community, things I think typically move from east to west. So as they come into our community, are you saying it could take us 3 months, 9 months to identify we have a new substance? I mean, I know there's our law enforcement, probably some of the doctors are recognizing a lot faster, but the health department. Yeah.
Well, so yes and no. So if it comes just from the deaths that we see, it'll take us a few months, but I'm assuming that we'll have coordination if we find something. On the other hand, we have other data sets where we can look at substance use, and it's also not a perfect system by any stretch of the imagination. There's another system that looks at hospitalizations and emergency room visits, and they do testing in that, and then we have a person on our team for the time being, who looks at that data on a very regular basis, like on a weekly basis, to say, is there anything unusual showing up in these substances? And so that data set, it's abbreviated by the term ESSENCE, it's called syndromic surveillance, and we can look at that data set. And I know that there are people at the state who also look at that data set on a regular basis, looking to identify any unusual outbreaks. And so they have a method to use that one to say, there's something weird going on here, reaching out to us. We've looked at that and said, actually there were some duplicates in there, so it's nothing actually relevant there. And then when we've heard about substances that are occurring in other parts of the country, then one of our people will go into those records and say, hey, is there anything that looks like that? Are any of the symptoms the same, any of the names the same, any of the potential street names the same, to try and get at that. It's not perfect because it's dependent on the knowledge of one person, but there are different pieces coming from different places to try and make sure we're not caught in the dark for some of these.
Right, and it's good just to have a heads up that this is here, and we need to, okay.
Yeah. But most of that information is preliminary, so we as the health department probably wouldn't share it out unless we found something that was notable in there. So that's probably why you haven't heard about that.
All right, thank you.
You're welcome.
Thank you for those questions. Any other questions from the committee? Well, thank you. You got one? Okay. Committee Member Yamby.
Thank you, Mr. Chair. So I have a question. What are some of the long-term obstacles to this work that we're talking about? Are there any challenges that you see coming up that make this work more difficult, potentially more difficult than we are? Because right now it seems that, things are moving. We're doing data sharing agreements. We're able to, work with each other, and, it seems like, this is a good time right now, and it's productive. But is there any potential obstacles? We've got budget coming up. We've got, a federal administration and on its own agenda. And, so what are the, upcoming potential obstacles that we could run into in this kind of forward progress that we've been making here?
We haven't been able to clone Ingrid. We're working on that.
I mean, I mean, you've heard about several of our obstacles. I mean, there's just the making these data sharing agreements. It takes time because you can't just fill out a piece of paper and say, sure, we'll do this. We promise to be kind and take care of the data. People want to make sure that we are doing things the right way, and they want to make sure that all the lawyers on all sides actually do allow for that. So I think data sharing agreements are an obstacle, but I think that everybody knows at many levels of the health department and the county and the city and the nation and the state that this is an issue. And I know that there's some progress being made on streamlining some of the data sharing agreements between, for example, the state and the counties. So that is an obstacle that would certainly help matters out. And we don't know how that will play out with all of this. I think also, I mean, one of the things that you've talked about is just the names of individuals in the homeless management system may or may not be the right person. You mentioned somebody named Jerry. Don't know who they are, but names is always going to be an issue. Names are personal identifiers, and people may or may not like the one that they have. And so I think the name issue is actually an issue, and I know it sounds crazy, but it is an issue, and will make all of the data linkages difficult, and we have to be careful, right?
Yeah, I mean, other countries have these very comprehensive electronic health records. We don't have that. Our data is scattered over dozens of data sets, and we don't, it's not like you just go to data.com and grab it. And we're trying to, improve our collaboration with people like the medical examiner and also with, I sit on the Continuum of Care board for the subcommittee for the HMIS, making those bridges and making those collaborations is what the health department is doing now, right? I mean, we can't do our work without doing that. And I think any way you guys can help in trying to bridge those gaps. If you see a collaboration that might be beneficial to the health department, please reach out and we can continue the conversation.
So it looks like we have somebody online. Is it Miss Owens? I can't see that far.
That is Dr. Owens is our supervisor.
Okay, Dr. Owens. Okay.
Yes.
Hey, welcome. She looked like she wanted to have something to say.
Yeah, just wanted to I appreciated that final question in terms of thinking around what are some of the long-term obstacles, and I wanted to highlight is capacity. It's not just cloning Ingrid, it's cloning Cam and some of our other epidemiologists. And as we are shrinking, we have competing priorities. And so when we have respiratory season coming up, we do have to figure out how do we navigate data sharing agreements that take a very long time. It's an investment to get done. And how do we also manage the other workloads that we have that are a competing priority for this work? So that's a big thing coming up in the next year is the amount of work that goes into this and the other items that we also have to keep as a priority for this team. So I just wanted to highlight that as a long-term obstacle that does kind of impact and shift how we do some of this work in the long run. Thank you.
Thank you.
All right. Well, I just want to say thank you again for all this hard work. It's so important to get this data right and as best as we can because it kind of helps us shape policy and programs. And it is a crisis. We get that quarterly report.
Yep.
It's between 250 to 300 people every 3 months in Pierce County alone. If we had 250, 300 people dying in a winter, over a 3-month period for DUIs, we'd have emphasis patrols out. We would be doing some major things to curb that. When we have a snowstorm, we have snow plows out, plowing snow, putting gravel down so people aren't sliding off the road and dying. This is a crisis, and we need to get a hold of it. And thank you for the work you're doing on knuckling it down for the details so we can use the good data to shape policies and programs. It's so important. It's the people of Pierce County. So thank you for your work, and we look forward to seeing how it digests out. So thank you.
Appreciate it.
Okay. I didn't have it on the meeting agenda, but I think there's some people here. I might want to open it up for a public hearing if there's no
comment?
Public comment, not public hearing, but public comment. If there's no objection to that, you guys can be excused, yes. Yeah, sorry about that. Yeah. And just as a reminder, we don't do too many public comments, but public comments all come, you make your public comment to the chair. It's not a question and answer. It's timed, and you can speak on it. If you wanted more detailed information or a question and answer, you can schedule some time with your council member or stuff like that to really knuckle down. But if you want to, if someone inside the room wants to make a public comment, come up to the mic and you'll have 3 minutes. Is there anybody? Come on up, and if you can say your name for the record, that'd be great. So your timer is going to be right over here.
Okay, Chair
Yes.
Herrera.
Yes, sir.
Thanks for having me. Frank Kokar, I live in Roy. So my son died from fentanyl 4 years ago, and when they were talking about the data sets, some of the things, are pretty skewed, especially when you start talking about all this combination of information that comes in from other agencies, the EMS, the hospital, the rehab center, all that information. And this was in 2021, so things have probably gotten better. I had to pull all that information myself to get to, my attorney, who I ended up civil suing 4 kids that were selling it. One of them admitted to doing it. And part of the reason I had to civil sue was, like the director was saying, toxicology reports come back 4 months later. So the kids that, I knew who they were, but the cops weren't going to do anything for 4 months until they got a toxicology report. And for most people, that 4 months, I mean, that's just a ticket for these guys selling it to get the hell out of Dodge, So it's a big deal for the cops because they have no probable cause when your kid's laying in the bed, deceased. And the only thing you can tell them is that maybe he died from a fentanyl overdose, So, of course, we had a detective come out and do a death scene investigation, which that case number was cleared off. But even after suing these kids, I still can't get any action. And that part reason is because of the prosecuting attorney's office. They don't have enough to go on, basically, is what they're telling me. So anyway, I just wanted to say part of this deal with the medical examiner, the report, it'd be good if we could get something quicker to the police. Right, so they have some kind of a test where they can say, okay, well this guy's gone from this. We can go knock on this door, and maybe try to get some answers. So that's not happening. These people they know, and I hate to say it, but we're a sanctuary state. So where do you think all these bad guys are going to come? They're not going to leave Washington. They're going to come here where they can hide. It's only going to get worse. That's why the numbers are going up. So,
Frank, if you can summarize it, we're out of time.
So anyway, okay, that's fine. Well, that's what I wanted to say, and this is my first time being here, and thought I'd share it with everybody. So, all right.
Thank you. Is there anybody else in chambers?
Good afternoon.
Thank you.
Councilmember Herrera. You know me. Heard me speak a couple times. I'm John Liddy. July 6th will be 2 years since my son passed from fentanyl poisoning. I don't call it an overdose, it's a poisoning. He lived in an Oxford house in Lakewood. Was clean for a year. We thought we had the old Johnny back. Definitely clean. I saw his eyes. He was a functional user of drugs, like a functioning alcoholic. They go to work every day. There are functional drug users. He was introduced to opioids through carpal tunnel surgery, where he was the wrong guy to give an opioid to. I'd like to find that doctor myself. He purchased in Pierce County, just moved from Lakewood to Lewis County, and on his purchased it on the 4th. His daughter's birthday was on the 5th, Luca, and now on the 6th was his first chance to use this. So he was having a stress. He was very stressed out about his move, his safety zone. You know how parents know their children very well. Lewis County referred me to Pierce County because Pierce County, the product was purchased in Pierce County. And I waited, the DEA worked on this, and also Lewis County. I have the guy's number in the DEA in Lewis County in my phone. They came, I came down, I didn't hear anything for 2 months out of this prosecutor's office, which is a joke, okay? Your kid dies, and I hear nothing. They turned it to Pierce County did nothing, sat there, did nothing. So I called down there, went around the DEA, they told me, John, we're not going to try this case. We're not going to look at this case. You can't prove that this girl who's been arrested 32 times, she's like a salmon, catch and release, okay? That's Washington. So why so long, Mary Robinette? This person, like I said, has been let go many times. I do believe that Washington Sanctuary State is hurting because the criminals see it's a great place to come and set up shop. So 21 million came into this country. How many are the bad guys? $6 billion industry. We don't feel safe. Look at the state now as to what it used to be, okay? It's been under one political party for a long time. Jay Inslee said, I don't want to fill up my jails with small-time dealers, but instead he filled up the morgues, okay? Remember that. You could tell him I said so. And my thing is, for me, the only way I'm going to get it is the feds are the only answer. Thank you.
Okay, is there anybody else in chambers?
Good afternoon. To our elected officials and to our employed people here, I appreciate your presence, but I am very, very deeply confused. I thought I was coming to a safety council meeting. I've come to support my friend John and now my new friend who's lost a child, and hopefully I don't lose my son to alcoholism, but I have 3 recovery dates. April 1st, 1992, I quit smoking cigarettes. 7/17/17, I quit drinking just because I quit drinking. And on February 3rd of this year, I quit taking oxycodone. So I took 40 milligrams of oxycodone a day. I've had about 17 orthopedic surgeries. And I just decided I was going to quit. And if none of you have ever just quit doing something, I can promise you that quitting the oxycodone, I got no assistance from my doctors who actually offered me a lesser. I tried Googling what is my body going to go through when I quit taking this medication, and there was nothing other than how I could obtain methadone. So I hear all of your data and your statistics. I appreciate it, but what does it have to do with...
Just to the chair, but you can speak.
Okay, yeah. I'm sorry. I appreciate statistics, but I don't understand what anybody's actually doing for these people, because if they do not have changes of clothing, if they do not have food, water, warmth, maybe something to take the edge off for a while, your body goes through hell, and they cannot do it by being on the streets. And Paul, I appreciate the fact that you were talking about putting them into a home that the state provides, and then they die in the home that the state provides. I mean, whoop, big whoop. What are you actually doing? What is the safety committee doing to help these people, because they can't just stop? I have a whole new feeling for these people on the streets. So I live on Lake Tapps. I walked into my neighborhood one day, we were cleaning up litter, and there was fentanyl right on our beautiful sign to the entry of our neighborhood. Somebody just left it there for some sucker to come along and try it out. And that's it. It's a done deal. So I would rather hear, and one of the things that was said was that there was a fear of the police getting the statistics. That really, really bothers me. Why would we fear our police finding out the statistics? So time's up. I hope these people get something more than just data, facts, and statistics. It's not cutting it.
Thank you. Mm-hmm. Is there anybody else in chambers? Welcome.
Hi, Chair. Couple of things, and I'll be really short. One, everyone works for us. Why are we negotiating with ourselves? Why are these things not accepted? Why are we asking permission to get our own data? It doesn't make any sense. And when you finally get the numbers back from 2023, they better be 395 homeless deaths, because that's what there were. I know that. And as far as effort, we've got 860 people that have died in the last 5 years that were homeless. How many did we miss in the last 2 years because of data problems? I'm sorry, I come from the Fortune 100. Fix it. Find the person who will fix it. And thank you very much for your work and for your help. Thank you.
Thank you. Oh, can you tell us your name real quick for the record? Sorry.
Oh, sure. Ed Jacobs.
Thank you. All right. Is there anybody else in chambers? Is there anybody else in chambers? Oh, we'll check online if there's anybody online.
Yes, Mr. Chair. For any members of the public who should provide comment, press the raise hand icon in Zoom or *9 on your telephone keypad. And there are no hands, Mr. Chair.
Thank you. We'll close the public comment and bring it back to item number 6, other business. Ms. Kelly, what do we got for our next Public Safety Committee meeting?
Thank you, Chair. Your next Public Safety Committee is scheduled for July 14th. However, that is canceled due to committee reduction. So the next scheduled meeting at this time is July 28th. At that meeting, we will have the rescheduled crime trends update from the Pierce County Sheriff's Office and an update on diversion services in Pierce County. That will likely be another panel discussion.
Okay, thank you. Some more data, important stuff. So, all right, is there anything else? Hearing none, we are adjourned.